Thank you, Dr. Rajesh. Can you see my slides?
Yes, we can. Please go ahead.
Thank you. And this penetrating keratoplasty, to refine this technique, we have to have some certain things we have to pay attention. First one is to prepare the patient properly, to prepare not only the ocular surface, being a full thickness graft, like we have to prepare the rest of the internal structures also, especially the anterior segment. And also we have to do a proper donor selection. And it's a open globe procedure. So during the surgery, we have to take care of this, and we have to pay attention to certain things. And also mainly the sizing and suturing, which is going to decide about the optical outcome of these grafts. So the donor facts, of course, we all know, like we want a good donor, but need not be so excellent as in case of EK, but we need young corneas relatively, I mean, preferably young corneas with a fresh immediate preservation. And if it is due to sudden death, due to cardiac arrest or something with normal metabolism, it's more preferable because the decay will be relatively less. And we have to prepare the ocular surface as well as the internal ocular structures accordingly, like which will hinder or damage the new graft. We have to take care of all of them before going for surgery. And also if the view is not good, we have to do the imaging techniques to assess the rest of the globe, especially the posterior segment, to get to assess the visual potential. And coming to the technique as such, the surgical technique, the anesthesia is very important in being an open globe procedure. Either we need, we need complete akinesia and a long-lasting anesthesia also. And we should be able to control the intraocular pressure and the BP well throughout the procedure. This is very, very important because this is an open globe procedure. In young patients, the anxiety can increase the BP and that can lead on to problem. And in elderly patient, the atherosclerosis itself can cause extrachoroidal hemorrhage and other problems. So it's preferable to go for either monitored intravenous anesthesia or general anesthesia. And when going for the speculum is, again, we have to choose a speculum which will not give any pressure on the globe. And also we have to take care of the scleral rigidity, like if it is less, as in case of myopes or aphakic eyes or children, keratoconic eye, better to go for Farringhast ring so that we'll prevent the scleral collapse during the surgery. And coming to the preparation of the host area, I prefer to center it to the pupillary center, not for the anatomical corneal center, because the pupillary center only will reduce your astigmatism or will give good visual results. And it's better to do it before dilating the pupil or before the anesthesia. And after that, you can use the markers if to aid your sutures also. And initially, we have to mark and assess the what graft size we are going to choose, and it should encompass all the pathological area, and also like it should not be too large or too low. Very small graft can lead on to high astigmatism. Large graft, of course, we are scared of graft rejection, and sometimes we may need to slightly decenter it to cover the pupillary area, or if the pathology is decentered, we have to go for a larger graft also. And vacuum refine is more preferable because you have more control to the depth to which you are refining before entering the anterior chamber. And punching the donor cornea, of course, we do it. We always choose a little larger one, usually 0.5 millimeter, 0.25 to 0.75, to reduce the chance for glaucoma, also to maintain the contour. And going from the endothelial side gives us a little more endothelial surface also to the donor graft. And coming to the suture, this is most important thing because this is going to decide the visual outcome. And here we have to go to almost 80 to 90% depth. So when on the graft side, the cut donor side, if you see, you can see a sharp glistening edge. That is the Descemet's membrane, and just above, the suture should come out just above that. So you go on both sides to the same depth, and also on both sides, the distance should be equal. And the distance between each suture should also be equal. And then only you will get a uniform compression and uniform tension on this suture, on the cornea. And either we can also use continuous suture, but in continuous suture, we have to keep one thing in mind. the bite what you are taking, we are used to a straight bite, and when you are taking it over to the next bite, the external portion will be diagonal. So this can cause a torque of the torque force on the graft. And so to counter this, some people use the anti-torque. That is, they take the diagonal for bite, and then the outer portion will be straight. Or we can go for an anti-torque method where both will be diagonal. So this is a little bit complicated. The continuous suture is not as an easy one as you think, and I prefer personally to the interrupted suture, because you can control the tension better there, and also you can avoid surprise astigmatism there when compared to the continuous suture. And I prefer it only for larger grafts, and I used to mix and match. And another advantage of interrupted suture is when the graft and host, the thickness is not matching, then it's easy to control our bite depth accordingly in the interrupted suture, and also later suture manipulation also will be easier in interrupted suture. So let us see a small video which is going to show this. The first, we just marked and assessed the donor size, the graft size, and then we are going for a little larger donor. And this is a crude punch what we are using. We were using, now we changed it, because sometimes you can get oblique cuts here. And then you do not enter initially, then you enter and inject some OVD. Here you can see this OVD is just flowing. This is only a dispersive OVD, but nowadays we prefer a cohesive OVD, either a hyaluronate or a combination of sodium chondroitin sulfate and the sodium hyaluronate. Then the first 4 sutures, cardinal sutures, will be first done, and this is very important. So you have to do it properly, and sometimes we may need to remove and put again, so that to get a proper regular diamond shape on the donor cornea. And I prefer to just to compress. I don't like to compress it too much to get that diamond so obviously and all. Thus I prefer only the just apposition of the graft. And after doing this, you have to fill up the gaps. So you go exactly in the center of the adjacent 2 sutures, and then the opposite, diagonally opposite suture you have to put, not the adjacent suture. Then only the main you can maintain the tension properly all around. So because of editing, I am just showing that as though I am doing the adjacent sutures like one by one. And at the end, you may need to even remove and replace the cardinal sutures also, because many times these cardinal sutures, by the time they become loose or they are not very radial, then you have to remove and replace them. And then you have to remove the OVD, which I prefer to go by the side port. I don't want to again intervene or open the graft host, the opposed graft host junction. So either you can make this side port before you enter the anterior chamber, before you trephine completely, or you can do it at the end. So then you can wash off the OVD completely, and then that is the end of the procedure. So like this you can, and the cohesive OVD is easier to wash off also. So the end, this is a relevant procedure even now. In certain conditions we have to go for PKP only. And being an open sky procedure, many of you, the cataract surgeons, nowadays the students are not used to open sky procedures, so they have to learn it very carefully, and better to go for GA or monitored anesthesia in such cases. And it can give excellent results if you properly prepare the patient as well as the your surgical technique, where you pay attention especially to the suturing technique and also the sizing and the positioning of the graft. So, and another thing, we have to make a lifelong partnership, because even later procedures like cataract or something, when you have to plan, in case of PKP, you have to be a little bit more careful, because it again, we have to plan the IOL calculation, all those things.